When the body's internal chemistry drifts out of balance, we intervene with pharmaceutical acidifiers. These inorganic compounds are designed to lower the pH in targeted fluids and restore physiological stability. But in their raw form, these chemicals are aggressive. They exist as concentrated gases and highly corrosive salts that must be captured, neutralized, and diluted before they ever come near human tissue. The body functions as a series of isolated chemical zones. A treatment that works inside the contained environment of the stomach would be ineffective or even dangerous if it were applied to the systemic bloodstream. The first intervention zone is the stomach. It's an isolated pocket designed to hold a concentrated pool of acid to break down food. The second zone is the systemic network, the interconnected circulatory and renal systems. Here, pH balance is a whole-body equilibrium managed by the liver and kidneys. Because these zones are so different, acidifiers work through two distinct methods. One provides a direct structural replacement for missing acid, while the other triggers a metabolic shift to move the pH indirectly. These two paths are represented by dilute hydrochloric acid and ammonium chloride. While both ultimately lower pH, they reach that goal through entirely different chemical and metabolic routes. Choosing the wrong route creates specific risks. You are either looking at the physical erosion of healthy tissue or a toxic accumulation of metabolic byproducts in the blood. Dilute hydrochloric acid begins at an industrial scale. It requires massive chemical processing long before it reaches a medical environment. To create it, concentrated sulfuric acid is directly reacted with sodium chloride. This generates a heavy, highly caustic hydrogen chloride gas. That gas is captured in purified water and heavily diluted. The final pharmaceutical grade is an aqueous solution containing exactly 10% hydrochloric acid by weight. Even at 10%, it is highly volatile. It must be stored in glass-stoppered containers. If the seal isn't tight or the room gets warm, the acid evaporates into the air. To verify this concentration is accurate, pharmacists use a standard laboratory assay. As shown in this protocol, the process is a direct acid-base titration against 1 normal sodium hydroxide. This reaction instantly produces sodium chloride and water. Because it's a direct neutralization, the concentration is confirmed without intermediate steps or complex reagents. This straightforward chemistry makes the solution highly stable in the bottle, but stability disappears if storage protocols aren't strictly followed. Clinically, this acid is used to treat achlorhydria, a condition where the stomach's parietal cells stop producing their own acid. By taking dilute HCl orally, the patient is physically replacing the missing acid. It drops the gastric pH instantly, substituting for the failed biological process. This drop is critical. Once the pH falls below 6, it triggers the conversion of pepsinogen into pepsin. Without that acidic environment, the body cannot create enzymes needed to digest protein. However, introducing raw acid to the mouth creates a physical trade-off. It is highly corrosive. To protect the patient, the acid must be diluted in 25 to 50 parts water and sipped through a glass straw. This bypasses the teeth entirely to prevent structural erosion. It's an effective localized solution, but it places a heavy administrative burden on the patient to avoid permanent tissue damage. The second agent is ammonium chloride. It functions as a systemic proacid rather than a direct acid, and that difference begins with its chemistry. It is produced by neutralizing ammonia with hydrochloric acid, resulting in a coarse, white crystalline powder. This salt is extremely hygroscopic. It aggressively absorbs moisture from the air, causing the crystals to clump and eventually melt into a liquid mess. To prevent this degradation, it must be kept in tightly closed containers. If the seal fails, the drug loses its chemical integrity before reaching the patient. Verifying the purity of this salt is also more complex than a simple HCl titration. This assay requires an indirect method. The pharmacist adds a neutralized formaldehyde solution to the sample first. The formaldehyde converts the ammonium salt into methylene amine. This reaction releases the hydrochloric acid, which is then titrated to confirm the dose. While a dry powder is easier to transport than liquid acid, confirming that powder's purity requires a much more sophisticated laboratory setup. Clinically, ammonium chloride is usually given in oral doses of 2 to 5 grams per day. Unlike the liquid acid, the powder doesn't change pH in the stomach. It relies entirely on the liver to transform it into an active acidifier. This flowchart shows the hepatic pathway. The liver breaks the compound down, converting ammonia into urea and releasing hydrogen and chloride ions into the blood. This systemic release corrects metabolic alkalosis, creating a mild diuretic effect as ions pass through the kidneys. However, at much smaller doses, around 300 milligrams, the drug serves a completely different purpose. It acts as an expectorant by irritating the bronchial mucosa. This increases respiratory secretions, making it easier to clear the lungs, though it causes mild nausea. The critical risk here is the reliance on organ function. If the patient has a damaged liver or kidneys, the metabolic process fails, leading to a toxic buildup of ammonia in the body. Ammonium chloride is a versatile systemic tool, but it carries hidden risks. If the patient's organs can't process the load, it leads to severe hyperchloremic metabolic acidosis. The choice between these two agents comes down to matching the mechanism to the specific physiological need. We compare them across 4 parameters: agent, mechanism, target use, and primary risk. Dilute hydrochloric acid is a direct acid used for localized gastric deficits. Its main risk is physical corrosion to the mouth and teeth. Ammonium chloride is an indirect proacid for systemic chemistry. Its main risk is metabolic failure within the liver or kidneys. Use dilute HCl when the stomach itself has failed to produce acid, as long as the patient can strictly follow the dilution and straw protocols. Choose ammonium chloride for whole-body chemistry or lung clearance, but avoid it entirely in patients with compromised organs.